Hello there, how are you? Welcome to Teapot, Cardiology, the physician of tomorrow, that being you. My name is Dr. Carlo Raj, and what we're doing today is going to be relevant cardiology in its truest form from subjects that perhaps you might have gone to different resources. We're going to do a story, and that's what medicine is. And at this point, you've gotten accustomed to it. I'll be bringing in the relevant embryology, anatomy, physiology, pathology, micro, and so forth, so that you get a good picture of what kind of questions that you'll be asked either on your boards or your wards in cardiology. Now remember, it's always me making sure that I'm current with the information. And with that said, we are going to begin with the mediastinum. And with the mediastinum, of course, the middle mediastinum being where the heart will be situated. But before we do any of that, instead of walking you through the anatomy and then having you memorize, let's give you presentations. Let's say that you have a patient that came in and just had a cardiac procedure. Post-operatively, less than 14 days, less than 2 weeks, the patient presents with fever, perhaps chest pain. And then at this point, what might you be thinking post-operatively with the cardiac procedure that may have given this type of presentation of fever and chest pain? How about some mediastinitis? Yeah, mediastinitis. That will be asked either on your boards or will be presented to you on the wards, and you have to be able to identify it based on the procedure and the complications thereafter. Now, that would be more or less a acute nature. Now, I know it's 2 weeks, but it would be an acute nature. What if your patient had lung issues, respiratory, presented kind of like pneumonia, but then also had maybe a history of going through a cave and exploring? The most common systemic fungal infection that may have occurred in that type of patient, perhaps Histoplasma capsulatum, then presents with, once again, fever, chest pain, has inflammation of the mediastinum. Then the issue here, you're talking about months down the road. And this would be called chronic mediastinitis versus less than 2 weeks, cardiac procedure being the most common. Months down the road, histoplasma, another name for chronic mediastinitis, is fibrosing mediastinitis. Now, with that said, what else could possibly happen chronically with fibrosing mediastinitis? And here's a chest x-ray showing you as well chronic mediastinitis. So you can see here right off the bat that even though we're doing cardiology in the surrounding area, based on the fact that your patient had a cardiac procedure, may present with certain symptomology. And then you have to come to find out as to what the etiology of that was. And here we covered mediastinitis, postoperatively, most common cardiac procedures, less than 14 days. Or months down the road after a systemic fungal infection, histoplasma, and the technical term fibrosing mediastinitis, but you should know that as being chronic. Of course, chronicity means more fibrotic deposition, doesn't it? Okay, well, while we're in the mediastinum, why don't we go ahead and divide it clinically, huh? Let's say that you had a patient in which this particular tumor that was resected and looked at, you saw different forms of ectoderm, endoderm, mesoderm, a tumor that has all 3 germ layers. Components of the eyes, components of the teeth, components of the hair. Dr. Raj, what does that have to do with anything here that's going on with the mediastinum? Well, the particular tumor that I'm referring to, and most common presentation that you probably have become accustomed to, would be perhaps an ovarian teratoma, right? But that's the ovaries in a female. Here I'm talking about the anterior mediastinum. So it is possible that you may have a teratoma. Remember, teratoma, a derivation of all 3 germ layers, correct? So I gave you hair components, maybe cartilage, maybe eye components, located in the anterior mediastinum. That's a possibility. What else could possibly happen? Well, if you're in the anterior mediastinum, what if you had a patient that had a thyroid issue? A goiter of whatever type, from secondary to hypo or hyperthyroidism? That may present in the anterior mediastinum. Or what if the patient had a lady that wakes up in the morning, feels pretty good. About 12 o'clock, the eyes start getting fatigued. At 4 o'clock, she's not able to get out of her chair. And then you do something called a hydrophonium test, in which her strength increases. Number one differential, you should be thinking myasthenia gravis. Okay. But in addition, with myasthenia gravis, what organ in the anterior mediastinum might be enlarged? Oh, the thymus. So in the anterior mediastinum, what kind of issues might you be looking for? A teratoma? Sure. A thyroid issue? Yes. Perhaps a thymus that I gave you here with the presentation of myasthenia gravis. Could it be a lymphoma? Sure. That's the anterior mediastinum. So here you're noticing that just with the compartment of the thoracic cage in the mediastinum, we're giving you a bunch of differentials dealing with the mediastinum. What about the middle mediastinum? What if your patient was drinking alcohol, went through Barrett's esophagus, and at this point, what kind of esophageal cancer is this patient going to develop? Adenocarcinoma. That would be in the middle mediastinum. What else could occur here? How about a hiatal hernia, in which the weakening of the diaphragm is causing herniation of the stomach into the thoracic cage? What if it's metastasis? Or perhaps a bronchogenic cyst? So understand the big picture. And I'll be repeating many of these issues over and over and over again. What about the posterior mediastinum? In the posterior mediastinum, you might be looking at neurogenic etiology. So in other words, something like maybe perhaps a neurofibroma. Is that clear? So that gives you a brief little summary of where we are with cardiology and the fact that even though you're dealing with the heart, that I want to begin by looking at the mediastinum.